In your handout, there's quite an extensive definition of palliative care, and instead of reading this off to you, I thought I would just highlight some of the key components. This is from the World Health Organization back in 1990, and you'll see this is probably one of the most quoted definitions of palliative care, and it really encompasses the total active care of the patient. So we're not just looking at the patient as individual parts. We see that a lot in medicine where whether it's the inpatient or the outpatient setting, where we have a patient who is admitted for multiple medical conditions, and the patient may have a cardiac consult, a consult from a nephrologist, maybe an oncologist, but nobody's really talking to each other very much. And the palliative care setting, we try to have all of those conversations, and we have everybody looking at the entire patient as a whole instead of individual body parts, so the kidney or the heart or things like that. Excuse me. We think about palliative care at the point where a patient is diagnosed with a life-limiting illness. So it could be a cancer patient, and it could be a patient with congestive heart failure or COPD. More often than not, we think about palliative care or hospice associated with cancer patients, but that's not always the case. Excuse me. About 50% of the patients in hospice may be cancer, but there may be more than 50% of the patients who have another illness. Excuse me. Just getting over a cold, and it's catching up with me talking so much today. We think about palliative care with the goal of managing symptoms and pain management. So this is really the mainstay of therapy in palliative care, and where pharmacists can really have a huge impact. The overall goal is to impact quality of life, not only for the patient but the family. So we're treating the patient, making sure that the patient is involved in all of the decisions with palliative care, but also the family as well. And it doesn't just stop at the time of death when we think about a patient in hospice, but it continues beyond that point in bereavement care as well. So taking care of the family needs that may need support after that point. And also we think about the psychological, spiritual, and social aspects of the patient and the family as well. And this is why we have chaplains, social workers as part of the palliative care team. Excuse me. More often than not, we think about treating patients in the inpatient, outpatient setting with the goal of cure in mind. And often this curative therapy or curative care is based on diagnoses. Patients are viewed as parts, as I mentioned earlier. So you may have 5 different consults for the patient. Each specialist may be looking after their own part. So the cardiologist, the nephrologist, the pulmonologist, the oncologist. But nobody's really looking at the whole patient and thinking about where is that patient going to be in 1 week, 1 month, or maybe a year from now. And it's often a multidisciplinary approach, which we'll talk about what that means in a few minutes. And under the aspect of curative care, we think about death as being a failure. Versus palliative care, it's kind of an accepted thing. And what we want to try to do is make sure, as I mentioned earlier, the goal is to keep the patient as comfortable as possible, respect their wishes, and see what they need to do in the limited time that they may have left. The goals under palliative care, obviously, as I mentioned, were symptom control. This may or may not include pain management, but usually pain is a vital component here. The patient is viewed more as a whole, so you're kind of looking after all of those parts as one big picture. So instead of saying, yeah, I can fix the kidneys, but the heart's not working, everyone's looking at saying, okay, well, the heart's not working, and so, where are we going with therapy here? So that's a little bit different. The care is a little bit more individualized and interdisciplinary as well. More often than not, even in the inpatient setting where I practice, the palliative care service, not a lot of people really are either that familiar with it or really know what it means. And A lot of times there's kind of a misconception that the palliative care service is kind of known as the death service, unfortunately. So there's a stigma associated with it. And palliative care isn't really the step right before hospice or the step right before death. It's actually a continuum of care. And often we try to intervene at the step where a patient has a life-limiting illness, which may be considered non-curable. So again, this could be a heart failure patient, a COPD, cancer patient, for example. Most of the time we think about palliative care on the continuum of being that of which the life-limiting illness has about a life expectancy of about 12 months. Could be plus or minus, it's not absolute, it's an empiric number. But we still think about palliative care as maybe an example is a cancer patient still undergoing cancer treatment. So they could still get their chemotherapy and their radiation therapy, but we know that the patient may not be cured. But what we do throughout this period is support the patient with a lot of social aspects, advanced directives, symptom control, things like that, a lot of discussions that go on through this continuum. And it's up to the patient to decide when they might want to stop therapy, or having discussions with the oncologist at that point when their therapy either no longer works, or maybe they've just gotten to a point where they said, you know, I've had some toxicities, I just don't want any more treatment. So this is where palliative care can have a great impact, working with some of these teams in some of these discussions with the patient and other healthcare professionals. At about 6 months, this is where we think about hospice, so a patient who has a life expectancy of about 6 months or less. And this is where the Medicare hospice benefit officially kicks in at this point. And so again, it's a continuum. So patients, unfortunately, may get admitted into hospice more often than not too late, instead of at an earlier point where they still have some viable time left, and to take care of a lot of things that they might want to do with their family and improve quality of life. And then finally we get to the point of death and bereavement care. As I mentioned earlier, it continues on past this. There are support services for families, for example, or for children. There's many support services for children who may need it if they've lost a parent. So there's a lot of things that pharmacists can do to impact the life of a patient in palliative care or hospice. And in 2002, the American Society of Health System Pharmacists actually published a position paper on the role of pharmacists in hospice and palliative care. So I'd like to go through some of those positions that they stated within their paper, and also expand on that and share some information on what we do at our practice site at Sparrow. One of the first positions that ASHP mentioned was making sure that pharmacists ensure the appropriateness of medication orders and ensuring the timely provision of effective medications for symptom control. And what this really goes back to is not only making sure that all the I's are dotted and the T's are crossed on the prescription, but taking it a step further and thinking about pharmaceutical care, and going back to the old school of pharmaceutical care and looking at the clinical aspect. Is the medication the correct one for the patient? What are the goals of this medication for this disease state? Looking at drug interactions, obviously doses which go along with the medication order. Where it gets a little bit more challenging in the palliative care setting, other than some of the general medicine setting, is that often in these patients we have to think about alternate dosage forms or dosage routes or other medications for patients. Especially in hospice, this becomes very important because we have a very limited number of dollars that we have allocated per patient per day that we can use for medications, and this is about less than $10 a day. So we don't always want to suggest the latest and greatest medications for these patients, because that will really bust our budgets extremely. And a lot of the medications, the older medications, are just as good as some of the new ones. So we have a great impact in some of these areas here. The other thing is making sure that we have medications available to the patient when they need this. And it's a little bit easier on the inpatient setting because the patient can hit their call button and get the pain medication when they need it. However, in the outpatient setting, when the patient is maybe at hospice or an outpatient palliative care patient, that they have the medications at home. And this is making sure, especially important in pain management. About a year, maybe 2 years ago now, one of the Pain and Symptom Management Advisory Board that I sit on, one of our challenges and one of our goals for the committee for the state of Michigan was ensuring that patients have access to adequate pain medication. And part of that was making sure that patients can get their medications from pharmacies. And does anybody remember here filling out a survey about that at all? Okay, it might have gone more to the, maybe, I don't know if anyone's administration here, but it might have gone up to some of the, at the admin level. We sent surveys out, information to all the pharmacies in the state of Michigan, requesting if they'd be interested in having their pharmacy listed as a pharmacy that would stock and carry opioids for patients with chronic pain conditions. And what they ended up doing with this list is putting it on the MAPS. I believe it's in the MAPS website. So that's where kind of all this came from. So that patients, if you don't, I know there's a lot of diversion out there and a lot of fear of having pharmacies robbed and things like that. So the goal here was if a patient comes to a particular pharmacy where medications aren't stocked, they could refer the patient to somewhere else where the medications could be available. We hear a lot of stories from patients in the community where they have to kind of, I hate to use the word doctor shop because it's got a negative connotation, but in this situation where they really are pharmacy shop, maybe is a better word, where they have to go around and find a pharmacy that stocks their medications for either the high number of tablets that they need per day or per month, or even the dosage form might be a little bit higher than average. So this is where this really is vital, and we've tried to have some steps in the state of Michigan to help patients out in that realm. So wherever you're practicing, if you can do that, this is why, and this really helps making sure they've got things at home, because pain and nausea and many other symptoms don't happen at 10 o'clock in the morning when your doctor's available, your pharmacy's open. It's 2 o'clock or 3 o'clock in the morning when everything's closed or there's limited access to medications. So keep that in mind and make sure patients have enough medications at home. Some of the other positions for pharmacists to actively get enrolled in, or involved in with palliative care involve counseling and education with the palliative care teams. So if you are in an inpatient setting or sometimes even an outpatient and you may service hospice and you have enough staff or the ability to go and sit in on some of the rounds and discussions that they have about patient care, please try to get involved. It's very interesting. You get a lot of questions. Everybody does work as an interdisciplinary team member, but pharmacists really have a huge impact on talking about dosage forms, what's available, what some of the new drugs. I always make sure when a new pain medication comes out, we do a formulary review on the medication. I send it out to our hospice team, our palliative care team, and give them information about it. Usually it's more expensive, so it's not something we consider right up front. But Exalgo we actually added that to our formulary because that was the only extended release hydromorphone at the time. So that was something that we were able to provide. One of the other big things as well is drug shortages. Remember when Roxanol was short, which made oxycodone concentrated solution? I was getting paged all the time for those for patients going home or trying to make sure they had a bottle to take home with them. So those are some challenges there. And many times we provide education. We've tried to do some educational in-services for our team over the last couple years on different symptoms, making sure we're up to date with literature and things like that. So we really have a huge role around medication therapy. One of the other position statements is making sure that patients and the caregivers understand the directions on their pain medication. The best example here is Roxanol. It's a concentrated solution, so making sure that we provide the appropriate dropper bottle, measurement tools that the patients can understand and use. And again, depending on the age of the patient and things like that. So that's something for counseling that is vital in this palliative care setting. Extemporaneous compounding is another one. This really happens a lot more in hospice, and I'm not an expert in some of these compounded formulations, but at least I know who to contact, and usually it's one of the hospice pharmacists, whether it's inpatient or outpatient. They usually have a nice book of recipes for different gels or topical gels for pain, for example, different ways that they can formulate medications into suppositories. I know our inpatient hospice, there's formulations on how to make very, very concentrated drips, things that we don't even allow in the hospital for patients requiring very large opioid doses. So these are some great areas that we can get involved in as well. Another one is financial concerns. As I mentioned earlier, the cost of medications can be quite extreme depending on what you're using. So helping with patients find assistance programs. Again, being on the inpatient side, I don't get personally involved in a lot of this, but more often than not, I'll contact the case manager, the social worker, and we'll work together. A lot of my students, it's been fun because we've got all the PDAs and the smartphones, and we're looking up formularies for different health insurances and things like that. So sometimes before we recommend an opioid, we may look into some of these things, making sure that it's covered under a different insurance plan if they're on the outpatient side. One of the other things is the safe and legal disposal of medications. This is a big problem in hospice when patients get to that point, especially in the outpatient setting, because they usually have a lot of controlled substances at home. Just a personal story of a side note, I had a close friend whose mother was dying about a year ago, and many times we'd get together and she'd be telling me giving me updates of what's going on and different things, and she's not in the medical field. And after her mother passed away, she just had this great idea. She was involved in the church quite a bit with her family and friends and that. She says, I'm going to take all the medications and donate them to the church. And I said, well, you have a lot of controlled substances in there, the morphine and the Valium and all that. And I said, you really shouldn't do that. But she just had the best heart and the good intentions of doing this. So these are some limitations we have with our controlled substances. So unfortunately, we recommend at this point at least to bring them back to the pharmacy or flush them down the toilet, which is, I believe, what most of the hospice nurses do after patients pass away. And the last but not least is the regulatory agencies. So keeping good records of all of this controlled substances and things like that go through the pharmacy. That's always the funnest part of all of our jobs, I think. But making sure that we keep up with those things as well. Now, as I mentioned, many different roles of the pharmacist here, and there's a lot of overlap that can occur as well. And I mentioned that really in palliative care we have an interdisciplinary team, and I mentioned some of the team members that we have on our service. And all of our roles, even though I'm the pharmacist and we have a nurse over here and a case manager, we really try to help each other out and do the same thing and help with dosing. And a good example is if I'm not able to go on rounds one day, the nurse may page me and say, hey, I've done all the opioid calculations for this pain patient. Would you mind, when you get a chance, going up to the floor and double checking my calculations, making sure everything looks all right? Or they'll run everything by me on the phone. So it's not, even though it's my job, in some respects I think, okay, I know how to do the calculations and I know how to manipulate the opioids and think about dosage forms. It's not a turf war, okay? So I'm not saying, oh, that I should be doing that and not the nurse. It really, we work as team members in the best interest of the patient, and we don't get into that politics that you can unfortunately see with some of the multidisciplinary teams. So that's one aspect of palliative care that I really like, that everybody, again, is at the whole aspect of the patient and looking after the best interest of the patient overall. The National Comprehensive Cancer Network, or NCCN, published some guidelines on palliative care. It's kind of a little bit more specific to cancer patients, but really, if you look at these guidelines, they can apply to any patient with a life-limiting illness. And they have some components of palliative care that are kind of defined in all of these different categories. The first one is screening, and at all of these stages, pharmacists can have a role here. Sometimes I think about screening as kind of the function of the physician, or sometimes our nurse practitioners on our team, because they're kind of looking at the patient and thinking, okay, do they have 12 months of life to live or less, or is it longer than that, or are there some other issues going on? But a lot of times when I'm taking care of patients, even on the oncology side, I might stop and think, this patient might benefit from a palliative care consult, or having some discussions with some other team members. So this is another aspect where we can get involved and recommend palliative care for an individual patient. Assessment is a key thing as well. So again, assessing the patient for their needs, for their life expectancy. We look at cultural aspects. More often than not, we see patients of different ethnic backgrounds. Some patients don't believe in pain management, and those are very challenging to deal with. So these are some things that we have to deal with and think about alternative treatment plans. Interventions is probably the biggest aspect where pharmacists get involved, because this is really where our pharmacological management comes into play, and we'll talk about some of the symptoms here in a few minutes. There's always continual reassessment. So have we done a good job controlling pain? Have we done a good job controlling some of the symptoms? If we haven't, why haven't we? And let's think about some alternate therapies, or have the goals changed? What are the goals of the patient? So this is a continuum all the way throughout the treatment of a patient. And then, as I mentioned before, it doesn't just stop after the patient dies. We think about after care here, which can be some support services for patients and or for the patient's family and other family or other friends as well. So now I'd like to talk about some of the symptoms that we see most commonly in palliative care. There's quite a few more symptoms than I can possibly fit in this hour time frame, but I'll touch upon some of the most frequently ones that we see. These are listed here in the table, and some of the others that I have listed there on the right-hand side I won't really talk about very much, but hiccups and dry mouth are something that we see infrequently. Fatigue and depression we see quite frequently. Those probably deserve a whole presentation by themselves. So I won't really delve into those too much today, especially depression, because that is a common symptom that we see probably from the onset of diagnosis. And terminal restlessness is something that we can see in patients at the very end of life, if their pain's not controlled, or sometimes if there's a lot of spiritual issues going on, patients just are not comfortable, and we have a difficult time managing their pain and anxiety at that point. So all of the others listed here, we'll kind of take a minute and talk about each one of these. Pain, pain, and pain. I know that this is something I mentioned earlier is probably where we have the biggest impact and probably the most to do with a patient in palliative care and hospice. I'm not going to delve into a lot of pain today because, again, that deserves a whole topic, an hour, 2 hours, 5 hours, whatever, for pain management. But the mainstay of therapy for pain treatments, obviously non-pharmacological therapies. So things like relaxation, distraction techniques, pet therapy, music therapy, things like that. Even though I may not be an expert in those, I'll ask somebody and say, let's think about these in conjunction with our pharmacological treatments. When we think about pharmacological treatments, opioids, that's really our mainstay, and morphine is the gold standard. Morphine, morphine, and morphine. Even though in practice I'm not seeing morphine as much anymore, if you pick up any guideline, any book, it's going to tell you morphine is really what you should work with. We're seeing a lot more hydromorphone in practice. I don't know why this is. I see it on the inpatient. I hear about it on the outpatient setting. It's difficult I don't like hydromorphone. I think it's difficult to manage and convert sometimes. There's some conversion issues. And we talked about methadone this morning. We see a lot of methadone in palliative care and in hospice. So methadone isn't always a first-line therapy. It may be for some hospice settings, for example. But sometimes we do reserve methadone for patients who don't respond or have intolerable side effects to other opioids. So it just depends on your practice where people are using methadone. And again, as I mentioned this morning, it is a good opioid. It does have some good benefit and good pain efficacy. However, there are some limiting factors with some of the side effects and toxicities. The other component of pain management is adjunct therapy. So if a patient has bone pain, thinking about a corticosteroid or maybe an NSAID if there's no contraindication. So neuropathic pain requires a different class of medication as well. So those are all some things that need to be fully assessed and treated as part of your pain management regimen. The next symptom that we see quite frequently in the inpatient hospice setting, even outpatient settings, is dyspnea. This has also been known as air hunger, and you see this in about 70% of terminally ill patients. It's a subjective finding, just like pain is, but can impact quality of life quite significantly. There are some non-pharmacological therapies suggested, such as making sure the room is cool, sitting the patient up in their bed, having a fan, for example, that may help, and some other pharmacological therapies, such as some of the bronchodilators. Corticosteroids may help. There may be some limited benefit with both of these classes of drugs. Benzodiazepines may help if the etiology is that of anxiety, and diuretics if the etiology comes from fluid overload. So it just kind of depends in those unique situations there. And then finally we have opioids. So why would we use opioids when we think an opioid might cause respiratory depression? So has anyone seen morphine or any others used for shortness of breath? Yep, Aerolyze can be one of them. Yep, I've got a slide on this. I'll keep going here. Yep. So it's really not fully well understood why opioids work in this setting. There, has been suggested that there could be some localized effects on the lung. Are there opioid receptors in the lung? Is there a central effect on anxiety? So these could all play into potentially the mechanism behind using opioids for dyspnea. If you look at the literature, there isn't a lot to support their use. Unfortunately, most of it is anecdotal case reports that's been published maybe in palliative care journals, hospice journals, pain management journals. So there's a limited number of studies, but if you ask any hospice physician, they do work, or any palliative care team member, they usually will say that these agents do work. There was a meta-analysis that was published in Chest a few years back, and they looked at about 18 studies. 9 of these studies included nebulized opioids. 5 of the studies were actually eliminated from the final report of the meta-analysis. And what they concluded was that the oral or IV formulation of any of the opioids, mainly morphine is what they used, is more effective than the nebulized formulation. And one of their big outcomes, and I think most of these studies included patients with COPD, they concluded that there was no effect on exercise tolerance. Now, when we think of a patient in the palliative care hospice setting, we're usually not thinking of a goal of improving exercise or improving being able to walk 2 miles and they can only walk 100 feet. We're looking at quality life factors, so shortness of breath, are they feeling better overall, some of those overall global health type of things. So although the stats and the numbers may not look so great in that population, again at this point it is something that's worth a try. Here's a little bit of information on the nebulized opioids. We've used it several times on the inpatient settings. I think in hospice you might use it a little bit more, but these are just some suggested doses that you can start in opioid naive patients. Sometimes what we usually do in our setting on the inpatient is start the patient on a small dose of Roxanol and see how that works first, using it orally, and then if they're on a large dose of an opioid, then we'll switch them over to a nebulized formulation. And you can titrate these doses up as needed. Most of the data that you'll read is reported on morphine. However, you can use hydromorphone or fentanyl via the nebulized formulation. You just won't see as much published on that. The next symptom is anorexia and cachexia. We see this quite a bit in patients who have undergone extensive treatment, maybe for cancer or other disease states. And one of the biggest controversies in palliative care and hospice is aggressive nutritional support. Families often think that, you know, they may be starving their loved one by not feeding them, but we have to be careful because at the same time, by giving the patient more fluids, whether it's through a PEG tube or through TPN, may actually be more detrimental to the patient. You can cause a lot of fluid overload, a lot of gastric secretions, things like that. So there can be more problems. And that's often where some of the team members have a lot of discussions with the patient's families regarding nutritional support. As far as pharmacological therapies go and trying to help patients with their appetite maybe earlier on in the palliative care setting, trying to get them to boost their eating habits a little bit better. We have several classes of agents that could be tried. Corticosteroids, you know, a benefit of steroids is kind of increasing your appetite. Okay, people gain weight when they've been on steroids for a while. But if you really look at the data, especially in some of the debilitated patients, the efficacy really isn't as good as we think it is. And probably the best data is with Megace. And the big key thing with Megace or megestrol acetate is making sure that the dose is appropriate. So you need at least about 400 milligrams. It probably starts at about 160 up to about 400. So when you can maximize the dose, and unfortunately we have to use the liquid formulation, which can be a little bit more unpalatable for some patients. But I think the key thing there is making sure the dose is appropriate, because sometimes we see those underdosed. So I think most of the literature does support some benefit in cancer patients, AIDS patients with Megace. Now, one of the questions that we more recently get is the medical marijuana that's now available legally in the state of Michigan, and the use of cannabinoids such as dronabinol. And the medical marijuana data is very limited as far as, I don't think there is any smoked marijuana data in anorexia and cachexia, but certainly there is some literature with dronabinol in AIDS patients. And there is fairly limited benefit in AIDS patients when it comes to anorexia and cachexia, especially when you look at weight gain. So it is something, it's another alternative if the patient can't take Megace, something that you could try. The next symptom that we commonly see anywhere in the spectrum is nausea and vomiting. There's many etiologies behind this, and many of these etiologies, one of the reasons I put this up here is because it will drive which pharmacological treatment that we want to choose for our patient. Probably one of the most common one that we see is chemotherapy or radiation therapy induced nausea and vomiting. We have to always think about drugs. Our opioids can cause nausea and vomiting as well if we're not careful. Usually this side effect will go away after initiating therapy. After 3 to 5 days you will develop some tolerance to nausea and vomiting, but if it's problematic, you could add an antiemetic for these patients. Sometimes it may be motion or intracranial pressure, so it depends if the patient maybe has a tumor on their brainstem or in the brain or metastases to the brain. Metabolic problems can cause nausea and vomiting, so these need to be corrected as well. Bowel obstruction, this is a common etiology that we can see. Constipation by itself. So this can really be an easy thing to solve, making sure that the patient has a bowel regimen if they're receiving opioids, for example. One of them I have listed here is pharyngeal irritation. So patients who have mucositis or thrush, this can cause some stimulation of the GI tract and cause some nausea and vomiting, peptic ulcer disease. So just adding a proton pump inhibitor might help these patients, or an H2 antagonist at this point. And then finally, anxiety and pain. So if we look at some of the treatment for each of these, again, it will depend on the etiology. With chemotherapy, we bring out the big guns and the most expensive agents. These are the 5-HT3 antagonists. So we have ondansetron, dilasetron, and forgetting the third one, granisetron. For these agents, with or without a neurokinin 1 antagonist, this is your aprepitant or Emend, which is used for delayed nausea and vomiting. These regimens are extremely expensive and pretty much should be limited and indicated only in the patients who are actively receiving chemotherapy. I say that, but we often see ondansetron in our patients' situations because it has gone generic and it is a lot cheaper now. So I don't always argue that. It just depends on the etiology. If there is a GI etiology behind the nausea and vomiting. Opioid-induced nausea and vomiting, the site of action here is a chemoreceptor trigger zone in the brain versus a GI tract that we see with chemo. Agents here work with, for a different mechanism of action, the dopamine receptor antagonist, so metoclopramide is a good agent here. Prochlorperazine or haloperidol could be used. If a patient has motion sickness, or something affecting the brainstem, we think about some antihistamines, corticosteroids. Metabolic problems, try to correct those first, give adequate hydration where possible, and then again thinking of some of the agents that work on the chemoreceptor trigger zone may help with metabolic-induced nausea and vomiting. Bowel obstruction, we'll talk about that in a few minutes as a separate symptom to treat, but you can see some problems. It directly stimulates the GI tract. Corticosteroids are probably one of the mainstays of therapy here to manage that. And I forgot to mention earlier with the chemo, corticosteroids usually are used in conjunction with the 5-HT3s up front as well. Excuse me. Constipation, make sure that you have an adequate stool softener and laxative combination, especially if it's opioid-induced. The pharyngeal peptic ulcer disease, I mentioned that earlier. And then finally for anxiety or pain, again, try to treat the underlying cause here. If not, and that's not, you can't find an underlying cause, lorazepam or Ativan is probably your best option at this point. Bowel obstruction, this could be potentially life-threatening. We see this a lot with colon cancer patients or anybody who has any type of disease in cancer in the abdomen. Has a significant impact on quality of life, can cause nausea, vomiting, pain, overall distress. So if the patient can tolerate aggressive or adequate hydration, that should be chosen. And usually corticosteroids are the mainstay of therapy here. It's been suggested because the data doesn't look extremely great for using corticosteroids in this setting statistically, but if you don't see any improvement after 3 or 5 days, consider discontinuing the corticosteroid unless they need it for another reason, because you may not get any more benefit at that point. Insomnia and sedation, these are some potential problems that we see. Sometimes patients get their days and nights mixed up. And obviously, probably our mainstay here is Ativan. If you want something longer, you can use Valium. And then for sedation, we've got the Ritalin and the modafinil. I've not used modafinil. It's fairly expensive. It's just not something that we use in our practice. And we actually don't use the Ritalin very much either, but it is an option in some refractory patients if it's concerning that they're sleeping too much and want to be awake more often, and if they're on opioids as well. Delirium is always a difficult and challenging symptom to manage because there could be many etiologies behind delirium, and it's very difficult to know if it's a disease process or a drug that's being the cause of the problem. And as many of you might be aware, physicians are always happy to start pointing at drugs, and drugs are always the cause. They can be sometimes. So, review the medication list, make sure there's not any medications that could be discontinued that are unnecessary. Other metabolic conditions can cause delirium as well, sepsis, fever, and especially malignancies in the brain or metastases to the brain. And really our mainstay of treatment here is Haldol. Respiratory congestion is another thing that we often see. It's also known as the death rattle, especially in hospice. And really it's more problematic for the family than it is the patient. And one of the tricks that we have here is using one of the anticholinergics. So we use atropine, the ophthalmic solution. Anybody dispense this in outpatient, inpatient, so you're familiar with it. Suggested starting dose here, I think our hospice physician actually goes up to 3 to 4 drops. So you may see a variety of different dosage regimens being used here, and it can be dosed as needed. So patients may not need it around the clock, or the family members may not to administer around the clock. If that doesn't work, you could use scopolamine, either by sub-Q injection or the patch. Problem is it does take a little bit slower onset, especially the patch, if you need to use that in an outpatient setting. So you may have a delayed effect there. Anxiety is something that really goes hand in hand with pain management. We see both spectrums here. There's a lot of reasons for patients to be anxious, either because of their diagnosis, their pain that they have, they're worrying about things with their family, just a lot of stuff going on. And really, we try to think about some non-pharmacological techniques here. Some of these overlap with some of the techniques we use or suggest for pain management. Again, I'm not always an expert in these techniques, but I usually will try to ask somebody. Actually, the patient I talked about this morning who was on the methadone, because she was a young girl, she was 20, one of the things that I had suggested, because she wanted to be very independent and there was a lot of social issues going on with her family, with her parents. And so one of the things that we suggested with this young girl was to get a pet, because that would offer some distraction and it would offer her some sense of responsibility. And so we talked about that quite extensively on our team for her, because we thought that would really help with her pain. And unfortunately, we just weren't able to do that just because of barriers with the family and that. I think there was, issues with who she was staying with and things like that. So, I mean, it is something that's not an easy thing to commit to if patients are already ill, to have to try to take care of something else, but it does work wonders. We see pets often used in hospice, so you have pets come through certain days of the week or maybe on a daily basis. They'll come through and go visit the patients, and it's really calming and soothing for patients in those settings. Sometimes we'll get pets in the hospital. I think they've done that before on the pediatric floors. One of the other things is music therapy. We do a lot of this on our service. I mentioned earlier we have a music therapist. I haven't seen her in a while. I know she's been on maternity leave, but she would come in, I think, on Tuesdays, and we'd have some of our patients kind of starred on our list that we thought might benefit from her going in and finding out what type of music that patient likes, and providing CDs and things that they can listen to. So that was really beneficial. You'll see in hospice settings they'll have a harpist or somebody come in to play the piano. So those are some things that really help patients relax. And finally, in conjunction with non-pharmacological therapies, obviously we have some of the benzodiazepines that can help, and then finally haloperidol if the benzos aren't working. Constipation, this is a huge problem that we see all the time, and we need to make sure that we prophylax against constipation. So trying to make sure we prevent it before it occurs, especially in patients receiving opioids. You do not see tolerance develop to constipation, so therefore we have to add a bowel regimen up front, which consists of a stimulant laxative and a stool softener together. I mentioned this morning that often we just see patients on stool softeners. You need to make sure you have the combination. One of the things that often gets forgotten, as your opioid dose goes up, your bowel regimen needs to be adjusted as well. And we'll see some very aggressive titrations in hospice quite frequently with bowel regimens. The mechanism is a little bit different in some of the palliative care patients, specifically where it comes to electrolyte and water absorption. These patients may be nutritionally deficient and not have a lot of electrolytes or water within the bowel. And this is very important when we think about choosing agents to treat constipation. So when we're looking at the bulk-forming laxatives, the psyllium and fiber and bran, we want to avoid those in these patients because there's really no water in the bowel for these agents to take in and be absorbed and help with the constipation and move things through the gut. So we want to avoid these. Most often we'll use stimulant laxatives if we have to treat. So our bisacodyl and then osmotic laxatives can be used. Many hospice and palliative care have bowel regimens that they'll use to titrate up. Enemas can be used. Magnesium hydroxide, Maalox is good. And then finally, we do have methyl naltrexone, which is Relistor, which was an agent that was FDA approved. I forget the dates now, but it was several years ago now. For palliative care patients who are receiving, palliative care hospice, who are receiving opioid therapy. We've used this drug once. It's very expensive. We used it once on the inpatient side, went through a lot of hoops to be able to get it for this patient, and it ended up not working. So, and I'm not saying it's a bad drug and it doesn't work. One of the other hospice physicians outside of our health system, I contacted her and found out what her experience was with this agent, and she mentioned as well it didn't work in the few patients that she had tried it in, which goes back to the fact that sometimes the constipation isn't really due to one factor. So if you truly know, and which I don't know how you would absolutely know this, but if you know that the whole constipation problem is due to the opioid, then this drug might actually work. But when you have a patient where there might be multifactorial reasons for constipation, it may not be as beneficial as it otherwise would. And you have to be careful if it's contraindicated in patients with obstruction. So that was, I know another patient at one point we were going to try it in, and it was contraindicated in that patient, so it saved me a lot of work because we couldn't use it. So I avoided having to go through the large number of hoops to get the drug in. Diarrhea is another problem that we can see. Sometimes you see the constipation and the diarrhea alternating depending on the patient. Loperamide really is a mainstay of therapy here. It's kind of a no-brainer on that one. But in patients that have very high output fluid, diarrhea problems or vipoma, some of those unusual type of cancers, octreotide or sandostatin is an agent that could be used. It is expensive, especially a lot more expensive than loperamide, but does work very well. Sometimes just a sub-Q injection, a low dose, twice a day, really does a lot of good for some of these patients. So those are most of the symptoms that we see that we have a huge impact on. Sometimes, again, we have to think about alternate dosage forms. Can we give some of these medications by injection, rectal administration, some of the liquid formulations? When we think about palliative care, we think about patients with a life expectancy around 12 months versus hospice around 6 months. Again, remembering it's a continuum of care. Our biggest impact is trying to improve the quality of life in the time that the patients may have left. I had a couple students, gosh, it was probably a year or 2 years ago now. Every month when they rotate through either pain management or oncology, I have them do a case presentation. And there were two students who followed two patients that they both got very attached to during the 1 month that they were there. And they kind of met the patient the first day. The patients were admitted, and both patients died kind of right at the tail end, right before their case presentation. And as they were presenting and then we were discussing the patients afterwards, I could tell that it really bothered the students. They were, you know, a little bit, not really upset, but it just, you know, was kind of disheartening that their patients died, and, you know, they were kind of, I could tell they were struggling with that a little bit. So we had some more discussions about this, and I said, you know, it is, it's kind of sad that your patient died, but step back and think about what you did for those patients in that 1 month that you were here. You really helped build a relationship with that patient, and not only the patient but the family. You controlled their pain, and you controlled some of the other symptoms that that patient encountered. So there was nothing that you could do to help the patient live longer or not die, again going back to that curative treatment, but you had a huge impact, and I think that that is what should be the takeaway from some of those patients, that you really had a good relationship and impacted the quality of life in that time that they had left. And that's sometimes a perspective, you know, you think about working with patients in these settings, that it must be very depressing in that, and often it's not, because you really are able to make some great interventions and see the outcomes very quickly. So to see a patient with their pain managed overnight is really rewarding. And so I tried to bring that back into context with these students and see it from that perspective, because as pharmacists we really can help the patients quite a bit. And again, it's an interdisciplinary team approach, so it's not just me managing the patient or the nurse or the physician, it's all of us trying to communicate and talk about the patient and think about the best pain regimen and the doses and how to titrate those pain management meds up to the best of our ability. So if you have an opportunity wherever you're at, inpatient, outpatient setting, hopefully you'll see the need more and more for pharmacists in these settings. So get involved when you can. I know there's a lot of barriers with time and things like that, but I've seen a lot of publications, a lot of need for pharmacists in these roles. So wherever possible, encourage either yourself or your colleagues to get involved, because we really have a lot that we can help out with.